Thank you very much, Dr. Khalid. Thank you, Dr. Adil, for the invitation. Thank you for the organizing committee for inviting me. Sorry, it will be to be the in the last. Everybody is saturated, but I will try to be quick and precise. So my presentation is about the MIDCAB, which is the minimally invasive CABG or minimally invasive direct coronary artery bypass grafting. Minimally invasive surgery or minimally invasive surgeon is not only a small incision. My idea of minimally invasive is very broad, so you have to be minimally invasive in all the aspect of the surgery, not only cardiac surgery, any type of surgery or intervention. So minimally invasive, you have to get the wise decision, planning well before the surgery, and to know what you will do during the surgery exactly, not to take decision just during the procedure, and also anticipation if you have any complication which can happen in any surgery. To be minimally invasive also, you have to try to get suitable or an incision that is with the surgery, not to exaggerate things or take many incisions that is not needed. Also, handling tissue is important. Even you are doing normal sternotomy surgery, handling tissue with delicate is also a minimally invasive approach. You have to get short surgery. You have to try not to use the bypass, or if you use it, you have to be short, and also the cross clamp, same. Pain management during surgery, either by block or local, and after surgery in ICU, this also will make the surgery minimally invasive. You have to be simple also in the surgery, not too complex things. And as the cardiac surgery, as you complex things, it will get more and more complex. And also to be cost effective and very efficient. This is the classic CABG that done since 60 or 70 years. You can see how is it complex, including all the things, cannulation, cross clamp, cardioplegia, retrograde. So it is really, for somebody who is not a cardiac surgeon, something like mystery. Classic CABG, as you know all, everybody is get used to classic sternotomy CABG with bypass, surgeon, anesthesia, nurse, technicians. So everybody is happy and comfortable in the comfort zone. It will provide you a full access to the heart and ease, and if you have any complication, it will be very easy to deal with that complication. No special positions or instruments, so it is a straightforward. And classic CABG has a disadvantage of and the other side of pain, of psychological burden in our patient when you are talking to him to open the sternum. This is like, for them, is like a very huge burden. Bleeding, as you know, after opening the sternum, from the sternum, and prolonged healing. It will take up to 2 months after the surgery, plus the infection, the complications, and the most importantly for the patient is the cosmetic side. MIDCAB. So MIDCAB is a sternal sparing procedure to achieve surgical coronary revascularization, so without opening the sternum, and usually and most commonly off pump and without cross clamp. And this is my idea about the minimally invasive, to be minimally invasive really in every part of the surgery. There is 2 ways, either with lift, small mini thoracotomy, or with a robotic assisted surgery. Most frequently, and even in my practice, I'm doing it for isolated proximal LAD stenosis. And we did some cases of multivessel disease using the bypass, which is called this TCRAT, or a hybrid procedure with the intervention cardiologist, in doing some part by MIDCAB and the other by stenting. So this is the current time now debate by a small lift thoracotomy or the robotic way. Robotic way, we know all, is excellent, and it's really minimally invasive, and it's very advanced. But my idea about minimally invasive is to be simple and easy for any cardiac surgery to do that. So for robotic, it's now for just for some advanced centers where they have the ability to do that. But for the thoracotomy or the minimally invasive thoracotomy can be done anywhere. Indication, always we have the heart team discussion and the decision and consensus about any patient will go to the MIDCAB procedure. Isolated significant proximal LAD disease when the PCI is not advisable in complex lesions or not successful or not possible in case of CTOs. So this is the main indication to do a MIDCAB procedure. There is also another indication of instant restenosis in the LAD where the patient could be young and diabetic, and re-ballooning or stenting the same lesion will be not a good prognosis. Also, as I mentioned, as a part of hybrid revascularization. Contraindication, there is no absolute contraindication, but this is maybe the contraindication when you are start the program of MIDCAB to try to avoid this type of patient in cardiogenic shock or in emergency or very obese. But as you get the experience, you will try to do some of these patients. Patient selection, also this is the same idea. In the beginning of the learning curve, you will try to avoid, try to choose this type of patient, slim patient, vertically positioned heart. You have to choose also the LAD to be not calcified, epicardial, and the diameter will be enough to do the off-pump anastomosis. A technical aspect, I will talk about it in the video about the tips and tricks. Post-operative management, usually fast-tracked recovery concept, which is the main idea of doing minimally invasive. Early ambulation and aggressive physiotherapy, this is very essential. As you do a huge work in OR, you don't want to have atelectasis and long stay in the ICU. Good pain control, which is very, very important, either inside the OR by doing local or doing block by our colleague anesthesiologist, especially they call it the serratus anterior plan block. In OR, in ICU, after that, very important to start strong analgesia, especially in the first and second days, so the patient can go home quickly. Our experience in Prince Khalid bin Sultan Cardiac Center in Armed Forces Hospital South Region, we started the minimally invasive right mini thoracotomy for mitral and others in 2021, and we did about 237 cases in the right side approach, including mitral replacement, repair, tricuspid, ASDs, myxoma, and now I can see even more than 80% of our cases, mitral and tricuspid ASD, we are doing it all minimally invasive, even in older patient. Regarding MIDCAB, we started last year, and till now we did about 19 cases, 16 cases of pump Lima 2 LED, which is my favorite. I did 3 cases of multivessel disease, either for OM or BDA, using bypass without cross-clamping. Our experience in MIDCAB, no mortality, alhamdulillah, no major complications, no strokes. 1 case converted to a sternotomy. It was in the beginning of our experience because of injury to the LAD, so we had to convert and do venous graft. Rapid recovery and early discharge, this is the main outcome that I noticed in the patient. All of the patients, they take maximum 3-4 days, then they went home very happy. No reinfarction or rehospitalization till now for all the patients we did. So in conclusion, MIDCAB offer a benefit for our gold standard Lima 2 LED with excellent cosmosis and rapid recovery. So we still have the gold Lima 2 LED as a surgeon, so we have to use it in a better and in an excellent way for the patient and for us. Steep learning curve, as you know, it took me about 3-4 cases in the beginning to get the usual use of especially in harvesting the memory, because we can do off-pump, is not a big deal. Can I have 1 minute more? So, خلاص I finish. So in a steep learning curve, in the beginning, few cases, like 5, some people took 10 cases. After that, you will get used to the case and it will be easy procedure. Reported short, mid, and long-term outcome are excellent and validate the safety and the efficacy. And finally, the main idea of the MIDCAB with the left small thoracotomy to be adapted anywhere and with every cardiac surgeon. Thank you very much. I will just show you a live in a box case to mention about the technical aspect and the tips and tricks. So, case presentation, 65 years old male, diabetic smoker, history of PCI to LAD and CIRC 3 years back, admitted with non-STEMI, ejection fraction 40, no valvular disease. So this is the ideal indication. As you can see here, the LAD, good graftable LAD, but with complex, long proximal lesion, and totally occluded CIRC and RCA. So as you see here, this is the LAD with a very long, complex lesion. In the supine position, you are doing the cases, as you see. No need to abduct the arm. So supine position, about 15-degree elevation. You can see here we mark the most important, the sternum. If in case of emergency you have to convert, this is very important. Then you mark all the ribs, and usually we are going in the 5th intercostal space. Sometimes in the 4th. Sorry. Sometimes we are going in the 5th. You have to mark also the lower border of the ribs. And you have to put a mark also for the clamp in case you will clamp and do other vessels other than the LAD. We start by a small incision in the 4th intercostal space. I'm always trying to spare the muscle, so no need to cut the muscle, just spread the muscle to reach to the pericardium. As you see, this is what we call the soft tissue retractor. We are putting the soft tissue retractor. In many cases, I am not using a retractor, but I use it in this case just to be more clear for the camera. This is the mammary retractor, specially designed for the minimally invasive. It's from Geister. There is many from other companies, like from Lacroix Chevalier. Also, they have a nice one. So this retractor is very efficient, and it will raise the barbato. You can see it here in details. We have many blades, medium, small, and large. I start usually with the medium blade. So I start in the middle of the LAD. I'm using usually the instrument, the usual instrument for LAD. I'm not using a very specific instrument. Just in the proximal part of the LAD, we are using a long shafted clip. Otherwise, it is really the same instrument, no extra instrument. After that, I will reverse the retractor to go to the distal end of the LAD, and I put the small blade. As you see here, we are dissecting the lower part of the LAD to get extra length in case we need to go very distal in the LAD. So we are clipping now the distal part of the LAD with 3 large clips, and cutting after giving the heparin, a usual dose. We are cutting the lima As you see, Lima here, very long and can reach even to the apex. This is the view of the surgeon. It's very clear. LED is just under your working place. We open the pericardium longitudinally, as you see here, and you will see the LED just under under you. So is excellent view of the LED, and no need to do any pericardial traction or any maneuver as we are doing it in the off-pump procedure. So it is really excellent doing the LED, no manipulation of the heart at all. You can see the soft tissue retractor here. It's excellent. It gives you the space without tracting the ribs. It will give enough space for the stabilizer to use. You can see the LED now. It's just under my finger, very clear. And this is after putting the stabilizer, the octopus. This is specially also designed for the minimally invasive, but you can use the usual octopus. It's not a big difference, but this one will help more in the minimally invasive. We are dissecting the epicardium to reach the LED. As you can see, the white structure there is the LED with a 11 blade or sharp blade. We are opening the LED, as you see here. You can use also the blower to see the LED, and I'm using always the shunt. So no need to do any stitches, any more stitches. As I mentioned in the beginning, the idea to be less invasive and simple and easy so everybody can do the procedure. This is the LED after opening, advising my friend who will start this procedure just to open really the LED, no need to struggle while putting the shunt. So just open it very widely so you can insert the shunt with ease. This is the shunt. In this case, I started with 1.75 shunt. I inserted, but I noticed that it's not the good size in the LED, so there was some leak. So it's very important in these cases, off pump with minimally invasive, try to use the exact size of the shunt. Otherwise, you will have a lot of oozing, bleeding, then the patient will deteriorate, and suddenly in the middle of the anastomosis, you will get the patient crushed. So as you see here, I changed the shunt with a bigger size 2 shunt. And after that, you will notice that no more single drop of the blood coming from the LED. This is the LED after inserting of the shunt, very stable in the front of us. And you can see also the LED, the Lima, sorry, here, very long. And so we will prepare it now and open it to the exact or the good place where you will do the anastomosis. This is after finishing the anastomosis, tying. I'm doing it usually with 7-0 Prolene switcher. You have to be careful not to cut the stitch, because otherwise you will repeat all what you did now. This is the final step, just with the blower. I'm reviewing the anastomosis, and I'm very strict in this, not to have any bleeding, any oozing. Otherwise, I will take care of it at the same time. So all the idea to have the patient simple, going to the ICU, discharged without bleeding, without any complication. This is after finishing. As you can see with the soft retractor, you can see everything. This is the patient, very stable, no inotropes, approaching the ribs with a strong switcher, just 2 stitch, just to approaching the ribs. No need to take it very approximate. And after that, we will close the subcutaneous tissue, and thus closing the skin. You can see the incision now. It's about 3 to 4 centimeters, not very big. Patient shifted to ICU, no inotropes, extubated 2 hours. You can extubate inside OR, and went home 3rd day post-operative. So this is, in general, the MIDCAB surgery. Thank you very much.